Okay. So my name is Jennifer Cushon. I'm the manager with TB Prevention and Control Saskatchewan. And I'm just going to start our presentation by talking about epidemiology of TB in Saskatchewan, just provide a few highlights about our programming. Then Neil's discussion is going to be talking about provincial TB strategy, and then Dr. Sweet is an allocation successes and challenges, and also how we're addressing some of those challenges. So unfortunately, Dr. Chris Stewart wasn't able to make it. He's currently en route to Winnipeg. He's in the air. So sorry again, we weren't able to be there in person. But if we could just go to the third slide. So here we see that the TB rates in Saskatchewan over the past decade have been a lot higher than the national rate. The green line is the Saskatchewan rate, and you can see that it's trending downward slightly, but it's still definitely higher than the national rate. And then if we just go to the fourth slide here, there's a significant difference in the rates of TB in northern Saskatchewan compared to the rest of the province. These differences or inequities range from 11.9 to 15.2 times higher over the past 5 years. So it should be noted that northern residents comprise just over 3% of the total population in Saskatchewan, yet in 2016, for example, 43% of active cases occurred in this part of the province. So if we could just go to slide number 5, this map illustrates the much higher rates that we see in the northern part of the province. So the darker colors are, of course, higher incidence areas. So next slide, please. In large parts of Canada, the majority of TB cases are among foreign-born individuals, while in Saskatchewan, the majority of cases are among First Nations and Métis people. So we're seeing a lot of similarities with Manitoba. More recently, TB incidence has been decreasing among First Nations and Métis people, but increasing among our foreign-born residents. In northern Saskatchewan, however, the majority of cases are still predominantly among First Nations and Métis people. Next slide, please. So I wanted to just highlight a couple of interesting projects from the past couple years. So the first one is just BCG vaccination was discontinued in 2011 in Saskatchewan. Provincial pediatric TB rates had been decreasing prior to 2011 in the province, and this was partially due to a significant decrease in the proportion of pediatric cases that were diagnosed only clinically and not microbiologically. So we compared rates of severe TB among children before and after discontinuing BCG in 2011. Fortunately, we haven't seen increases in severe TB in children, so either miliary TB or TB meningitis, since discontinuing BCG in 2011. We've actually seen a decline in pediatric cases overall in the province as well. So based on an evidence review, as well as the findings that are up on the slide that you'll be looking at, we developed a new pediatric screening policy for the province last year. One of the priority populations for pediatric screening are children that reside or attend school in high-incidence communities in northern Saskatchewan, where the risk of latent tuberculosis infection is higher. So the next project I wanted to highlight is around TB genotyping. So TB genotyping is a tool that can add value to establishing linkages in contact investigation. Dr. David Alexander led work in the province that looked at mirror typing of isolates. His work showed that there were clear geographic associations in Saskatchewan, but because Saskatchewan has fairly homogeneous endemic strains of TB, he concluded that it's not an ideal genotyping method. It just doesn't precisely establish epidemiological linkages. So he suggested, as have others, that whole genome sequencing would offer a lot more promise to assist with demonstrating clear epidemiological linkages. So this will be a priority for our program in coming years. Next slide, please. So just a little bit about programming in the province. So the program that I work with is TB Prevention and Control Saskatchewan, and it's the provincial program that's responsible for the treatment of active and latent TB in the province. We have the only pharmacy that dispenses TB medications in Saskatchewan, with one small exception, which is the Refugee Health Clinic in Saskatoon that does some treatment of LTBI. We have 3 fixed offices in the province, one in Saskatoon, one in PA or Prince Albert, and then one in Regina. Clinics are held regularly in these 3 cities, and then we also conduct mobile and telehealth clinics with centers in northern Saskatchewan. So since Saskatchewan is a large province area-wise, and we only have these 3 fixed sites, we rely really heavily upon our partners to prevent TB and also treat TB. Next slide, please. So this slide just highlights the many partners that we work with to provide TB services in Saskatchewan. Some of the main partners that we work with in northern Saskatchewan to provide services are the First Nations and Inuit Health Branch with Indigenous Services, the Northern Intertribal Health Authority, and I believe they'll be speaking tomorrow about some of their evaluation work, and then the Northern Population Health Unit and also Saskatchewan Tribal Council. I'm now going to turn it over to Neil Cushon.
Hi, everybody. Really sorry that I couldn't be there to join everybody today. We had a pretty difficult decision this morning as we were sitting on the tarmac. Our original flight actually got canceled, and then we were informed there was some delays with our flight and that we could still get to Winnipeg, but we wouldn't get there till late in the day today, actually, before today's event concluded. So we really wanted to take advantage of the opportunity to present today, but also to learn from others that were sharing this morning. We were extremely humbled to receive the invitation, and it was a really tough decision because relationships are pretty important to myself personally. I was looking forward to meeting a lot of you that spoke this morning, actually, so really disappointed that I couldn't be there, but happy to share over the phone today. I just wanted to start out today. I had to change my notes a little bit. I wanted to do an honoring of with my feet firmly planted in Treaty 1 territory in the homeland of the Métis, but I'm doing it with my feet firmly planted in Treaty 6, also the homeland of the Métis. My name is Neil Cushon. I'm from the Fishing Lake First Nation in Treaty 4 territory in Saskatchewan. I'm currently the interim director for population public health with the Saskatchewan Health Authority, as well as the co-chair on the provincial TB strategy. Just wanted to thank you to Margaret and Siobhan and the NCCID for the invitation, and thank you very much, Kathy, for stepping in for me in my absence. Some of the comments that were spoken to this morning were really powerful and really resonated with me. Addie mentioned a lot of the social determinants of health issues, as well as made reference to the TRC. So those were things that I was thinking about as we were preparing our presentation, and was really happy that others spoke to those as well too. Thank you to Lynette from ITK. Actually read about the lawsuit that was launched on the tarmac this morning. But it's my role today to speak to the provincial governance structure, I guess, for the TB strategy. And it's a little bit difficult for me to speak over the phone, but I'll give you a little bit of an so if you could just close your eyes for a second and picture a smart, dashing individual speaking. It's not what I look like, but it might make me sound better, so I'll go with that. I just wanted to say a special thank you to Dr. Wong as well too. You know, those words really resonated with me, and I was looking forward to hearing all of the Miigwechs and Aminzagwas out in Treaty 1 territory as well too. And of course, a special thank you to the elders and the prayers. So for my slides, I'll get into them right now. So the provincial TB strategy is a comprehensive strategy that was required to respond to the high number of cases of TB in Saskatchewan. So much like everybody else, our story is similar to what we've heard this morning. There's an overrepresentation of Indigenous people when it comes to TB in Saskatchewan. And it's important that we all really work together. I'm fairly new to the team over here, only about a year I've been in the role and working with the TB team in Saskatchewan, but I've been nothing but impressed as I observe their work. It's a really comprehensive approach to dealing with a pretty serious situation in our province. And one of the things that it really reminds me of is Jordan's principle. I know that we've really got some more work to do on the policy end, but for some of the other areas that I work in, with the jurisdictional challenges that present themselves with working on reserve and off reserve, I've been afraid actually to ask that question to the Saskatchewan team, because I feel that I'm talking in the past. They're so far ahead, you know, so it's been really admirable to watch. Definitely higher rates of TB in Saskatchewan versus the rest of Canada, as well as the unique ethnic and geographic distribution of TB in Saskatchewan. So again, part of the partners that Jenny mentioned, you know, was that whole list there. I don't want to go through that list, but the work can't be done without all the contributions of those members on those teams. So one of the things that was done with the partnership was setting collective measurable goals as a group. And some of the goals I'll quickly just go through here is the first goal was to reduce the number of new and relapsing cases of TB. So in 2013, the TB strategy of Saskatchewan targeted a 25% reduction in the rate of new and relapsing cases of TB by 2017-2018, and a 50% reduction by 2022 to 2023. There was a rate of 8.1 per 100,000 in 2012, which decreased to 7.9 per 100,000 in 2016. One of the things I'd really like to point out, though, too, is that due to population growth, the rate decreased, although the case number increased. And the reality being, with small numbers, an increase or decrease of a few cases leads to considerable percentage changes. Next slide, please. The second goal is to really just facilitate quality patient care through early detection, best management, and timely treatment. The third one, again, is definitely one of the reasons that it was so important for us to participate again, is to continue to support ongoing capacity for healthcare providers to ensure consistent and collaborative management and treatment of TB. The fourth goal is again, we heard this morning, the importance of providing TB education and support for the general population, especially for those at highest risk. This next slide here it really speaks to how we function as a governance group. We've got all our partners at our committee table, as well as we've established some subcommittee groups, some focus groups, if you will. There's 5 areas. You could see them on the screen there. Some of the responsibilities of the Saskatchewan TB partnership are overseeing the implementation of the provincial strategy, including the high incidence communities work plan. You'll hear a little bit more about that tomorrow. Confirming the TB partnership as a governance model for the strategy and reviewing both the strategy and governance model to support TB prevention and control in Saskatchewan before the strategy ends in 2018. Endorsing standards, guidelines, and policies related to TB programming for Saskatchewan partners that were listed in Jennifer's slide. Receiving and responding to short, midterm, and long-term strategy evaluation recommendations. Endorsing research proposals that align with the strategy's goals and objectives, and accessing sufficient resources and allocating new resources for the full implementation of the strategy. So the strategy really guides the work of the focus group areas. We have 5 focus groups established, 4 of which currently have leads and members, currently looking to find leads for the quality improvement, program evaluation, and research focus groups. So we've approached this particular work a little bit differently. Next slide, please. So the first one, although the rates have been declining, we did not meet the targets for 2017-18. I mentioned a few of the reasons earlier. The second thing, we renewed the partnership. We established the committee, and in terms of reference, we've established focus groups and leads. Linkages to the First Nation TB Advisory Committee in the province. For priority setting, in May 2016, focus groups established some priorities, and the priorities aligned with the logic model and evaluation indicators. And the policy framework for the provincial policy, Jennifer mentioned the pediatric screening policy that was reviewed, revised, and approved. And in the fall of 2017, we hosted a 2-day planning session in Saskatchewan's north, and many in the room were involved. Great discussion, we had great attendance, and it was a really clinically focused event, so we're actually learning from the experience this morning of having that voice of lived experience in the room. It's really important, and I was glad to see how it worked so well this morning. The last thing for my portion is the evaluation plan. phase one of the evaluation of the strategy completed in 2015, and it was focused on short-term outcomes, and phase two is to be completed in mid-2018. So I'll turn it over to my colleague, Dr. Julie Krzyzanowski, who is one of the co-leads on the provincial piece.
Thank you, Neil. And good afternoon, everybody. My name is Julie Krzyzanowski. I'm a medical health officer here based in Saskatoon, and with the TB program, am the co-lead with Jenny Cushon and Diet for TB prevention and control, and with the TB partnership, the co-lead for the public health prevention and community engagement focus area of that strategy. And like Neil, I'd like to acknowledge that we're joining you today from Treaty 6 territory and the traditional homeland of the Métis. We're really fortunate and grateful that things worked out, that we were able to bridge to you there in Treaty 1 territory and also the homeland of the Métis. And also acknowledge that with TB prevention and control, we are providing services to the entire province of Saskatchewan and to people who are residing in multiple treaties, including Treaty 4, 6, 8, and 10. So Jenny and Neil have done a nice overview of the epidemiology and the TB partnership and the strategy for the elimination of TB in Saskatchewan. And my job is to highlight a few of the clinical successes that we've had. And I'm presenting for Chris Stewart today. These are not his words, so I'm giving my interpretation on the slides that he had prepared, but I will do my very best. With regards to high incidence communities in Saskatchewan, we've applied the definition from Health Canada's monitoring and performance framework for TB programs for First Nations on reserve to Saskatchewan epidemiology for both communities on and off reserve. And for these designated high incidence communities, we've implemented a number of measures, including implementing enhanced contact investigations. This is being supported by a database that's currently being developed and piloted in a couple of the communities that will allow us to collect additional information to monitor in real time progress on contact investigations. It will also allow us to identify and respond to outbreaks in a more timely manner, mobilize surge capacity, and provide targeted screening, as Jenny mentioned, to pediatric populations, including associate investigations, for which we are including in our policy, but also for HIV, people living with HIV in high incidence communities as well. And for community awareness, promoting that by providing to the communities and leaders in the communities community level data, and this is patterned after the type of health status reporting that we've been doing in Saskatoon and area using an integrated knowledge translation approach. So our colleague who is there today, Nambi Nabuka, will be presenting on the high incidence strategy evaluation, so I don't want to steal his thunder. Oh, switch slide, please. About the NISA Health Authority evaluation. I'll just foreshadow it a bit, saying that we did see some success in the three communities that were the focus of this evaluation, including an increase in LTI screening, a reduction in active cases, and a decrease in the ratio of SMER positive to SMER negative cases in the communities that were evaluated. Another success has been the expansion of treatment of latent TB infection. Implementing the guidelines as per the Canadian TB standards has increased the number of clients to whom we've been offering prophylaxis. Previously, we had administered all treatment of latent TB infection as directly observed treatment, but in the last couple of years have been expanding the use of that or self-administered treatment to dramatically increase the capacity to treat more people. And we've also been engaging primary care physicians in the treatment of latent TB infection, for example, with the refugee clinic here in Saskatoon. Switch slide, please. So another success has been screening all people who have been treated for active TB disease or latent TB infection for HIV at the time of diagnosis. Since 2011, this has been a policy of the TB prevention and control program. And the rates have been high. The policy is to screen all clients who are 13 years of age or over. And we are achieving fairly high rates, although it has been declining a little bit in the last couple of years. Next slide, please. We are aware that historically we've used a different criteria to identify high incidence communities in Saskatchewan. And with the new application of the Health Canada definition, that has meant, because of that change in surveillance, that we are identifying additional high incidence communities. So we need to adjust and adapt our strategy to cover these previously unidentified and unacknowledged high incidence communities. Next slide, please. So another one of the challenges that we're facing is delays in diagnosis and in the success of our contact investigation. There are high rates of passive case finding, and it's not uncommon to have smear-positive respiratory disease as the presentation. And with contact investigations, we have had difficulties recruiting and retaining clients who have been offered treatment for latent TB infection. And in fact, the clinic model that we're using, which is a mobile clinic model where a team from the 3 sites that Jenny mentioned would be traveling to remote or rural areas, attendance rates at those clinics have averaged about 50%. Another challenge in Saskatchewan is the prevalence of HIV in communities which are high incidence communities, and HIV-TB co-infection has been identified as a concern. Fortunately, we've not had outbreaks where this has been the pattern, but it is definitely something that we are working towards implementing approaches, including screening of HIV-positive populations in high incidence communities on an annual basis for TB. To address our challenges, we've taken some steps in recent years. So to improve delays in diagnosis, we are taking steps to move away from a physician model that is largely centralized and specialist-centric. So by providing the Gene Expert technology in Athabasca Health Authority in the far north, not only is this improving real-time access to diagnostics, but it's also accompanied by some healthcare provider education so that it's encouraging providers to think TB and test for TB because this technology is available in the community. To improve engagement for contact investigations, I mentioned the new contact investigation database that's being piloted previously. So this will allow for real-time monitoring and reporting, but in addition, providing diagnostics within the community to remove some of the barriers to engaging in treatment and care for latent TB infection, including the use of portable technologies and remote and virtual communication technologies. To improve community engagement, one example that has been provided is the Pathways Project. So developing a patient charter of rights and responsibilities in TB care, and looking to adopt this as part of TB prevention and control program policies, as well as a standard of practice and standard of care. And then finally, to expand community awareness and treatment of latent TB infection, the LTBI Mobilization Project, which is modeled after the Time of TB project, is underway in early stages of planning and implementation here in Saskatchewan in one of the high incidence community areas that we've identified. And this will include a door-to-door education campaign, expanded screening and prophylaxis, and then also the use of rifapentine to deliver more effective and patient-accepted therapy. And last but not least, we are looking at changing our clinic model away from a satellite clinic model with mobile clinics to one that is empowering and providing support to local primary care providers to be more engaged in the diagnosis and management of active TB and latent TB infection. And also, we recognize that this will require extensive community collaboration, and that's something we're looking forward to very much because we recognize that there is a historic legacy of TB treatment, and that's very true of Saskatchewan, and much of the stigma and barriers to care are the reasons why the rates are stubbornly high, and a new model of care is required to change that. pattern in that picture. So that is the end of the presentation, and I realize I'd forgotten to tell you to advance the slides for the last, so hopefully you've caught up with me here on the question slides, and I'll pause here and welcome Neil and Jenny to respond to any questions directed to them as well. Thank you.